more simple. I need only one question to be answered and one message to be delivered, which is screening. Colorectal cancer is most common cancer in men and second in women, and mortality is high, and this is a developing country reflect poor surveillance of these regions. And the colorectal is most occurring worldwide, and the second leading cause of death, third in female, the third common malignancy in both men after prostate and lung, and women after breast and lung cancer. And the colon is more 2 times than the rectal cancers. Men and women are the same. Age, it's more at the age of 40. The mean age is 72. It is higher in black than in white. And geographically, it's more in industrial places. There is many environmental which can lead to that, either diet or lifestyle or inflammatory bowel disease. And if you look to that, there are many factors which can be increased. I think we here in Africa has all these factors which lead to more cancers. Hereditary and non-hereditary products, familiar or hereditary syndromes, and inflammatory bowel disease. This is the causes of colorectal cancers. Majority are adenocarcinoma. Some have progressive tumor rise from adenoma, but most adenoma do not progress to cancer. Others, squamous cells, small cells, carcinoid, and else. When you diagnose at the so assembly, it should be initial work of digital examination, which many doctors don't do that, which is a very simple colonoscopy, biopsy in any detected lesions and the barium enema. And then staging, you should go to X-ray, CT scan, CBC liver function, and you can reach up to PET scan. Colonoscopy, it is sensitive, examine the colon, can perform a biopsy at the time of colonoscopy, in invasive risk of bleeding or bowel preparation. Sigmoidoscopy only can be performed at the time of sigmoidoscopy, examine the rectum and sigmoid, and then ocular blood examination. These are the 3 methods. There are many things about that. There are many things about ocular blood, many things about that. By my message, it will be very easy. So it's time to introduce, I think in some country, I think in Emirates and Saudi Arabia, in Kuwait, Kuwait, you start screening colonoscopy? Yes, so I think in Emirates and Kuwait, they start. So I speak about my area, which is Africa, which I was at training center, and Professor Naima, I think she's here. We don't start, you have in Morocco screening colonoscopy? We have, you have. For all populations? Not for all populations. So I think as I'm working in a Cairo training center belonging to the World Organization of Gastroenterology, we're thinking of introducing screening in Africa by colonoscopy. Yes, we need that. And the screening to whom? There is something with average risk, there is something with increased risk, and there is something with hereditary. And you should look for everyone who is in increased risk. And this is a many discussion happen with many patients. When you ask them, you need to do colonoscopy because you have an adenoma, or your family has cancers, or you have inflammatory bowel disease. This is increased risk. And also the risk if have a colon cancer less than 50 years. So you should look for that for a screening colonoscopy. And you should remember that the incidence increase with age, and if you look at age about 70, which is when the cancer possibility of the variant colorectal cancer is increasing, and this is very important also in screening. If you look for the colorectal cancer around the world in a WHO, and you see the map that it's nothing done about Africa, no many things, because very little published data about Africa. When I ask me about also NASH in Africa, I look for everything, and then we have a paper on NASH already published. We have very, very minimal data in Africa, some data in Saudi Arabia, some data in Emirates. So also we have no data in Africa about that, but we know that the incidence, it is very high. And there's the incidence of mortality also on that. If you look at this one from WHO, they said that Colorectal cancer is number 5 in cancers in nearly 4,000 diagnosed cases. So it's number 5 in this case. In Egypt, also, it's number 8 for the cancers in Egypt, but this is not for minimal study. This slide is very important to see these slides, because if you look here in early diagnosis, فين screen؟ اشتغل ده؟ Yes, this is في انتوا مش حاطين لي وقت ليه؟ Okay, so if you look here in early diagnosis, the 5-year survivor, it is reach about 100%. So this is very important when you're speaking about a screening colonoscopy or a screening program, either by colonoscopy, by anything else. So the incidence of mortality, as I said before, in developing countries is markedly decreased because they have a very good screening program. But here, after spreading to adjacent organ or lymph node, the survival rate is decreasing. When it's spread to distant metastasis, it's markedly decreasing. You should understand this very well. And if you look for this simple slide, the survival for early colorectal cancers is very high. These are people who survive, and these are the people who are dead fatality of colorectal cancer. So if the stage is very high, you get a high mortality. So we should be in this area, and should be in this area in our region in Africa. We should introduce screening colonoscopy. And this is colorectal cancer have declined high over the past 20 years due to improvement in screening. This is from outside, not from our country, not from African country. And this is the natural history of colorectal cancer: epithelium, adenoma, early adenoma, late adenoma, carcinoma, and situ. And this is all of these, until this one can be diagnosed, can be treated by endoscopy, and decrease the incidence of colorectal cancer. And normally, when you're staging colorectal cancer, 40% are localized, regional 35, and unstage is 4, distant is 21. It is the same here in our country or not? So the first question to all of you, anyone doing colonoscopy can raise his hand? Anyone doing colonoscopy? So the number, it is very good. Asma, you don't do colonoscopy? Yes, so the number, it is much. So if you ask another one, what is the number of colorectal cancer during the 12 months, the last 12 months, who have over 10 cases of colorectal cancer when you do colonoscopy? How many? So it is also high. Less than 10? Okay, little. So more the people have colorectal cancers, more than 10 cases when they examine. The next one is the most important. At time of colonoscopy, we have doing colonoscopy found the cancer with metastatic cancers. How many? Only 2. Without metastasis? Okay. So this means that the screening of colonoscopy is very good. But what I see in many areas that when we examine the case of colorectal cancer, it comes very late with advanced stage. So it was a time to do screening colonoscopy in Africa, yes. And normally, in your trainee now, it must be all the trainee should train basic endoscopy, which means upper and lower. And don't rush to very advanced endoscopy. We need that. We need many people doing colonoscopy. I think in the United Kingdom, they have a problem that they need many doctors to do screening colonoscopy. Because by screening colonoscopy, it's very easy. You can do an upper endoscopy, you do colonoscopy, you do bulbectomy, you do capsule endoscopy, and this is a basic, and this is very good. And the perfect colonoscopy has 3 components: complete and comfortable detection, all the pathology, safe, and the complete therapy. So, and this is maybe most important thing as a Cairo Training Center. We're training now up more than 300 doctors, more than 300, 350 doctors from all Africa, who should aware that the people should be aware about colonoscopy, should be aware about screening, should train colonoscopy, and should be motivated. And we should train them, and then practical, and they'll persist on that until they reach this situation with conscious and expert. And this needs a hell of work. Believe me, working on me and Professor Naima with Africa, it needs a hell of work to reach these situations. If you ask how many doing colonoscopy, in any African country you found 2 or 3 or 4 or 5. Egypt is different. We have a huge number here, but still we don't have a screening program. So now it's very important. And you should look for these pictures also, that many people, they don't like to do colonoscopy, and they don't afraid from that. And this is, we need also a public health and advertising about that. And then moving from number to quality indicators, you should have a good bowel preparation. You should have cecal intubation in more than 95%. You should withdrawal time in 6 minutes, resection of polyp less than 2 centimeters, adenoma detections more than 20, perforation less than 4. So this is the most important 3 things. You should have cecal intubations, you should have adenoma detection, you should have a less perforation. And this is, you are moving from number. I said I have 100 cases of colonoscopy. The more than that, what's your quality of colonoscopy? And this is a big problem also in many countries, that you do colonoscopy, but the quality of doing colonoscopy is very low because you don't reach the cecum, they cannot detect adenoma, they have some complications. And by this mean, if you have a good quality colonoscopy, it is difficult to introduce that in our country. As speaking at African doctors work in Egypt, we should reach these situations either in Egypt or in Africa. So it's time to introduce and time to training colonoscopy in Africa. Yes, and I think through the presence of Professor Naima as a president, with Cairo Training Center, will try to do the next 2 years in these programs. And we have one with the WGO in March. The first colonoscopy training in Egypt was the WGO, and we have 4 experts coming from WGO in March, and we select people to train the training. And this course is not to train colonoscopy. This course is train the trainer how to train people, and this under umbrella of WGO, it will be in the end of March with 4 doctors, and I think we will send it to all of you if you like to come for this one. And the trainer, take care also, the trainer should be competent, should be interested in the technique, should admire criticism, should easy to work, and should be hard workers. Polypectomy can decrease colorectal cancer by 80% if you do it, and if the size increases, the greater pregnancy, and also the pathology, the vellus more than tubular, vellus more than tubular, and also how to improve adenoma detection, as I said before, optimal bowel preparations, and the most important thing is this one, which is the withdrawal time. Some people can reach the cecum in 20 minutes, but the withdrawal colonoscopy in 2 minutes. So this is very important. You can detect all the polyps, especially the progress-related flat polyps. This is a take-home message, which encourages colorectal screening and also make an algorithm for that, for the screening. Building a screening program is not simple. It's a very difficult one. And all the people, like in Kuwait or like in Emirat, they know that they have a very good system. It's not easy to perform that. So we should do that in our country, should do that in Africa. Colonoscopy is standard, but still you have occult blood and you have the capsule endoscopy. This may be the last slide, but remember this very well. As you see that most of the people here, not most, but about 50%, we see this is the idea of this Congress, that most of the people here are not young doctors, but the next leaders all over the world, like many doctors here in the middle age, which now it will be the leader. You will replace us in the future. So please, for us and for the people who are training, take training very carefully. Why? Because the doctor who trained them, and you become ill after that, either me or anyone, and who will do for me the colonoscopy? The one I train him. So remember that today trainee are tomorrow endoscopists. And today trainer like us may be tomorrow patient. So take training very serious, because the man or the woman who train him, he will do for you colonoscopy. Waiting for you 2020 at 10 of December. Thank you.